Yes. So very good evening, everyone. Once again, welcome you all to the platform of learning in Cognized Nutrition. And today's discussion will be another very interesting topic on thalassemia. So from your school days, you are learning what is thalassemia, what is its consequences. But now it is the time as a practicing nutritionist or dietitian, it is very important to know the detail about the thalassemia. We don't know how much detail we can go into today's discussion, but we have tried our level best to clear many of your doubts. If we could not clear the doubts today, we have kept a separate session for the discussion so that we can do that. So I am going for the introduction of the speakers who will be discussing today's session. So I'm sharing the screen. And after that, we will have the discussion. It will be a bit interactive session. Still, I will request park your question at the end. And also thank you, batch 4 students. You have given a lot of questions. So we will try to answer all of your questions by today itself. We are trying our level best. The screen is being shared, hope. Yes. The screen is shared?
Yes, sir.
Yes, sir.
Okay. So we will be discussing this everything on the thalassemia, its treatment, its diagnosis, its diet. So today we have Debomita Sengupta. She is MSc in Dietetics and Food Service Management. She is also certified child nutritionist. She has completed the medical nutrition therapy from Cognized Nutrition along with the obesity management and cardiovascular management. She has also completed the diabetes educator course from Dr. Mohan's Academy, that is National Diabetes Educator Project. She has completed her 6-month internship from CMRI Hospital and also the virtual internship, which you all know it is conducted by IDEA RD board. And recently she is a consultant dietitian at a pharmaceutical companies in Kolkata. So our next speaker is Mrs. Patralika Dasgupta. She is also from Kolkata. She is also MSc in Dietetics and Food Service Management. And basically, she has completed her diploma in Medical Lab Technology at State Medical Faculty. By profession, she is Medical Laboratory Technologist at ESI Hospital, Kolkata. So she has a vast knowledge on the diagnosis parts of these kinds of diseases. She is also an online dietitian, practicing dietitian. She has also completed her medical nutrition therapy from Cognized Nutrition along with the other short courses from Cognized that are cardiovascular disease, obesity management, gastro and liver master classes from this organization. The third speaker who is Miss Prashasti Chatterjee, who lives in Hooghly, Srirampur, West Bengal. She is also BSc in Food and Nutrition honors from Calcutta University and Dietetics and Food Service Management from IGNOU. She is also certified diabetes educator from National Diabetes Educator Project, Dr. Mohan's, and she is the completed her medical nutrition therapy along with obesity and cardiovascular disease from Cognized Nutrition. So currently she is working in a private school and also having her own business, and she is also a practicing dietitian both offline and online. So with this, we are moving to the topic and distribution of the topic. The introductions about the disease and also the summary conclusions will be discussed by Ms. Debomita Sengupta. The classification, pathogenesis, mutation, understanding thalassemia, which is the very important part. And in this, whatever questions you have, you can ask at the end. So this technical things will be discussed by Mrs. Patralika Dasgupta. And the most important for the nutritionist and the dietitian is the diet relation between iron and thalassemia. Should we restrict iron? Should we not restrict iron? At what condition we will restrict? Everything will be discussed by Prashasti Chatterjee. So without further delay, I would like to invite Ms. Pritha Bose to share the screen and start our discussions. And ask the participants to switch on your video as I have requested. During your introductions, the video should be on for all the 3 participants.
Thank you, sir. I'll be sharing the screen immediately.
Yes, thank you, Patralika. You may switch on a little bit later. So let's Debomita start the presentation. So Debomita, welcome, and you can go ahead with the presentation.
Thank you, sir. Thank you for the kind introduction. I hope I'm audible and
visible. Screen sharing, Pritha. And Debomita, please instruct accordingly when to change the slides.
Sure, sir.
Thank you, Debomita.
I hope I'm audible and visible. Is my screen visible properly?
Yes.
Okay.
Yes, but screen is visible, but
will I start, sir?
Well, just a minute. Let her make it full screen. Rita, can you make it full screen, please? Debomita, go ahead with the introduction.
Sir, I am making it full screen, but I guess the same old problem is happening again.
Okay, you stop sharing that thing. Then again, I have to. These things should be practiced prior. That's why I request you 100 times. You stop sharing. Let me do the screen sharing. Okay. Also a case study. I'm trying. We will try to do that also at the end. So I'm keeping myself mute. I am trying to join from another device, Debomita, so that I can, if required, I can talk. Why not you are starting? Please start.
Okay, sir. Hello, everyone. Thank you for taking your time out on a Saturday evening. Good evening. I'm Debomita Sengupta, practicing nutritionist, currently working at a Kolkata-based corporate company. Today, with my sincere gratitude, I would like to thank Shomendu sir for organizing this session at Cognize Nutrition and giving me this opportunity to speak on this topic, thalassemia. Without any further delay, let me introduce this topic led by my fellow speakers, dietitian Patralika Dasgupta and dietitian Prashasti Chatterjee. So thalassemia means comes from two words, thalassa, which means sea, and hemia means blood. So it's a blood disorder due to problem related to the Mediterranean Sea. As we can all see here in the slide that the normal red blood cells gets malformed during thalassemia. So we can classify anemia into three types: microcytic anemia, depending on the mean corpuscular volume. When the mean corpuscular volume is less than 80, it is microcytic anemia. When it is 80 to 100, it is normocytic. And when it is above 100, it is macrocytic. So thalassemia falls under microcytic anemia. We all know that hemoglobin, can I have the next slide, sir? No, the previous one. The previous one. Can I have the next one? Next to this? And the next one? Okay, so set the previous one, please. Okay, so we know that hemoglobin found in RBC is essential to transport oxygen through cells to the body. Thalassemia occurs when the hemoglobin production is affected due to variant or missing genes. So hemoglobin is less produced, either sometimes leading to destruction of RBC called microcytosis condition. In mildest form, it results in anemia, while in severe form, it requires a lifetime of regular blood transfusion. In this slide, you can see that the red blood cells has been malformed in thalassemia. So it is as I have discussed, that it is a type of autosomal recessive genetic disorder caused by faulty hemoglobin synthesis due to mutation and deletion of the globin chain forming gene. It is a Mediterranean Sea problem, so it is widespread in Mediterranean, African, and Asian countries. Thalassemia are extremely heterogeneous at the molecular level. Over 200 different mutations occur here. The structure of normal hemoglobin is given here so that you can understand in a better way. Let me go through this, that hemoglobin is the iron-containing oxygen transport metalloprotein in red blood cells. It is composed of 4 globin chains, a ring-like, you can see here, organic compound known as the porphyrin. Yes, sir, the next slide. Okay, so here are the types and concentrations of hemoglobin in adults. There are mainly 3 types of hemoglobins, namely hemoglobin A or major adult hemoglobin. It is 95% consisting of 2 alpha and 2 beta globin chains. Hemoglobin A2 or minor adult hemoglobin. It is 2 to 3% consisting of 2 alpha and 2 delta globin chains. Hemoglobin F, it is only 1% consisting of 2 alpha and 2 gamma globin chains. For your reference, the pictorial presentation has been given on the right side. Can I have the next slide, please? Okay, the graphical presentation of different types of globin chains will be discussed by dietitian Patralika Dasgupta. Thank you.
Okay. Good evening, everybody. Good evening, sir and ma'am. I am Patralika Dasgupta. I have done my MSc in Dietetics and Food Service Management from IGNOU. Already, sir has introduced us. I am very much privileged to be a part of this awareness program and also a part of Cognize Nutrition. And everything having possible where our sir, Dr. Soumendra sir, is present. So my cordial respect to sir. Now, sir, okay. So today's topic is thalassemia. So we have to understand what is the thalassemia? What is the exact problem happening in thalassemia? Thalassemia is a type of hemoglobinopathy. Okay, that is the disorder of hemoglobin. So what is the function of normal hemoglobin? All of us know that hemoglobin carries oxygen forming oxyhemoglobin. So if there is any problem in hemoglobin, what happens? Decrease oxygen supply to the body tissue, that is hypoxia. Already we know it from Debomita, the different types of hemoglobin and their concentration in adult. So normal adult hemoglobin consists of HbA, that is at normal adult, measured normal adult hemoglobin. Hemoglobin A2, HbA2 and HbF, that is fetal hemoglobin. So normal adult hemoglobin, that is hemoglobin A, comprises of 2 chains, 2 alpha and 2 beta chain. All are tetramers here. So normal hemoglobin is important to get body tissue sufficient amount of oxygen. Now we have to know about the formation of globin chain. Alpha. Now we have to understand the formation of globin chain. Please look at this graph. Sir, please slide number 7. Previous one. Okay. Please look at the graph. So here, if you notice the graph, we can see that before birth, at birth, and after birth, alpha chain synthesizes continuously, both in fetal life and in adult life, in very high concentration. But synthesis of gamma globulin chain is very high in fetal life, but after birth, it is drastically decreased. Look at the graph. But in case of beta globin chain synthesis, just the opposite happening here. What happened here? Beta globin chain synthesis is very low in fetus life, and after birth it becomes high, and after a certain age it is just equal to alpha globin chain synthesis. And the synthesis of gamma delta chain is start at birth and very low concentration after birth also. Okay, so next slide please. Please look at this chart. Suppose I am representing here the defective allele, that is the altered allele, as capital T. Defective allele, that is the altered allele, as capital T, and the normal gene, normal allele, as capital I. Okay. So if two carrier parents are going to be crossed, what will be the outcome in the first generation? Look at this picture. What will be the genotypes and phenotypes in the first generation? Here, father and mother both are trait or carrier. First genotype is capital I. So here is no altered gene. This individual is completely, absolutely normal. Next one is capital T, capital I. So here the altered gene is present, but altered gene is present in heterozygous condition, not in homozygous condition. The altered recessive allele is present in heterozygous state. And we know it very well, our recessive allele cannot express it in heterozygous state. Okay, so this individual is also unaffected, but this individual carry the altered genes to the next generation. It can transmit it to the next generation. Okay, gene present but not expressed. Gene present, altered gene present but not expressed. It is a carrier state. Next one is capital T, capital T. It is an affected individual. Why? Here she or he is suffering from thalassemia. You know one thing very well, that the recessive allele always express it in homozygous state. Look here, it is in the homozygous state. Capital T is capital T and capital T is homozygous state. Okay, so different types of genotype: capital I normal, capital T, capital I trait, and capital T is thalassemia major, that is affected individual. Okay, so here out of 4, 1 is normal, that is 25%. And out of 4, 2 is heterozygous, that is 50%. And out of 4, 1 is homozygous state, homozygous recessive state, that is 25% is affected. Okay. So next slide, please. Okay. So আমরা কি দেখছি যে adult hemoglobin এ alpha এবং beta globin chain present থাকে, 2 alpha and 2 beta. তাহলে our main focus is on the adult hemoglobin, that is major adult hemoglobin, that is hemoglobin A. Okay. Now I am going to the different types of thalassemia. Thalassemia are mainly classified into 2 types, 2 categories: alpha thalassemia and beta thalassemia. But clinically it is also classified as transfusion dependent thalassemia এবং non-transfusion dependent thalassemia. Okay, so first of all I am going to discuss about alpha thalassemia. So after birth हमारे पास क्या ज्यादा होता है? Alpha. But alpha तो हमेशा से ही high है. Also we have got beta chain, beta globin chain after birth, high and equal amount as alpha. Okay, this is a normal phenomenon. But if there is any defect in alpha or beta globin chain synthesis, then what will happen? After birth we have low concentration of delta and gamma also. Okay, if alpha combined with delta, what will form it? HbA2. We have already known it from Debomita. Alpha combined with delta forming HbA2, and alpha combined with gamma forming HbA, that is fetal hemoglobin. Okay, but when the abnormality arises due to mutation or deletion in the alpha gene, in the gene or allele, deletion or mutation in the allele or gene, this condition is called thalassemia. Okay, when any abnormalities arise due to mutation or deletion, this condition is called thalassemia. Now we will talk about alpha thalassemia. In case of alpha thalassemia, there is a decreased production of alpha globin chain synthesis. And gene of alpha globin is located where? Chromosome number 16. There are two genes for alpha globin chain synthesis. What are that? HbA1 and HbA2. We know each chromosome has two homologous pair. Each chromosome has its homologous pair, one coming from father and one from mother. Okay, and each consists of two genes. So there are 4 allele for alpha globin chain synthesis. Okay, two in one chromatid, 2 in another chromatid. That is 4 allele present for alpha globin chain synthesis. Now, what happened in alpha thalassemia? Either due to deletion or mutation, out of these 4 allele, some or all affected. So, what will happen? Alpha chain synthesis totally decrease হয়ে যাবে ঠিক আছে this is in normal case alpha and beta synthesis almost equal in amount, isn't it? So here beta will not getting alpha for his pairing because alpha globin chain synthesis decrease হয়ে গেছে তাহলে beta কার সাথে পেয়ার করবে beta will not getting alpha for pairing. So there will be free access in beta globin chain. Now let's see what can be the different types of alpha thalassemia. So next slide, please. Okay. If 4 allele are normal, so alpha chain synthesis is normal. This is a normal case. Okay. If 1 out of 4 is deleted or mutated, this is called silent carrier. These individuals are totally asymptomatic and absolutely need no treatment. Okay. 1 mutated gene, this is called carrier, but this is silent carrier. Okay. Next one, number 2. If 2 gene out of 4 gene is deleted or mutated, what is called that? Called alpha thalassemia minor or alpha thalassemia trait. Okay. Alpha thalassemia minor or alpha thalassemia trait. If mutation or deletion of the gene from the same chromosome, it is called cis type. And if mutation or deletion from the different chromosome, this is called trans type. Okay. This individual also act as carrier. Why? Because they are also present an altered gene. Okay. Third one is if 3 gene out of 4 deleted or mutated, alpha globin chain synthesis will be drastically decreased. This is a drastically abnormal condition. Here forming HbH, that is tetramer of beta. So here beta pairing with own self. One 3 allele out of 4 is deleted. So beta paired with own self and forming tetramer of beta. This is a very severe condition. That is HbH consists of tetramer of beta chain. This forms the hinge body. That is HbH. That is the hinge body. This type of hemoglobin is totally unstable and precipitate within the cell, forming insoluble inclusion. That is called hinge body. This hinge body damage the RBC and further damage the erythrocyte precursor. Okay. So now the fourth one. If 4 gene out of 4 deleted or mutated, this is the most severe form of alpha thalassemia. This is the more severe form of alpha thalassemia. This is called alpha thalassemia major. Here forming the hemoglobin bars, that is forming the tetramer of gamma. Why? Fetal life to আমাদের শুধু alpha আর gamma থাকে তাই না? Fetal life to আমাদের beta থাকে না. So alpha totally deleted, alpha chain totally deleted, তাহলে gamma কি করবে? Gamma with pair with own self and forming the tetramer of gamma. Okay. So this is a very, very severe condition. And people with this type of disorder are not able to produce any functional hemoglobin, that is hemoglobin A, F and A2. কোনো functional hemoglobin এরা ফর্ম করতে পারে না। কেন পারে না? কারণ যে কোনো hemoglobin ফর্মেশনের জন্যই আমাদের আলফা চেইন দরকার হয়, আর আলফা চেইন এখানে একটাও প্রেজেন্ট নেই, so there is no hemoglobin. So here form four gamma globulin chain, that tetramer gamma. This clinical syndrome is called hydrops fetalis. Okay, hydrops fetalis and hemoglobin birth. This condition is not compatible with life. There can be severe uterine anemia. There can be severe uterine anemia, and this patient typically die in the uterus and or shortly after death. Okay, am I clear? So next slide, please. So slide number 11.
Ma'am?
Slide number 11. Okay. Okay. Who?
I'm Ashmi Thakur. Ma'am, I didn't understand the hemoglobin H type. That third point. Third type.
Okay. I'm telling. Hemoglobin H. Alpha thalassemia is what? There are four allele for in case of normal case. There are 4 allele for alpha globin chain synthesis. Okay. If 1 out of 4 deleted, that is called silent carrier. If 2 out of 4 deleted, that is called traitor carrier. If 3 out of 4 deleted, ঠিক আছে, বোঝা গেছে? If 3 gene out of 4 deleted or mutated, alpha globin chain synthesis drastically decreased. Drastically কমে যাবে alpha globin chain synthesis. তো alpha আর beta adult hemoglobin এতে কি থাকে? alpha and beta adult hemoglobin এ সেখান থেকে 3টে alpha chain চলে যাচ্ছে, তাহলে beta কার সাথে পেয়ার করবে? There will be free access for beta globin chain. Beta will pair with itself and forming the tetramer of beta. বোঝা গেছে? That is called hemoglobin H or tetramer of beta. Am I clear?
Yes, ma'am. Thank you, ma'am.
That is called HbH or tetramer of beta. Because adult hemoglobin only consists alpha and beta chain. And just different case happen in the case of where 4 allele deleted or mutated. There is no, it is happening in fetal life. There is no beta, only alpha and gamma. So gamma কার সাথে pair করবে? Gamma will pair with oneself and forming the tetramer of gamma. That is called HB bars, tetramer of gamma. This is a very fatal condition which I call hydrops fetalis. In this case, fetus died in the uterus or just after birth. Okay. Next segment, I am going to the beta thalassemia. In beta thalassemia, there is a decrease in beta globin chain synthesis. So we have to know what is the cause of it. Beta globin chain কেন সিনথেসিসটা কেন ডিক্রিজ করছে? We have to know the cause. So we already know beta globin chain gene located on what? Chromosome number 11. Okay, only alpha globin chain যে gene that is located on chromosome number 16. And rest of the gene that is for beta, delta and gamma located on chromosome number 11. Okay, so beta globin chain gene located on chromosome number 11. So beta thalassemia is monogenic. What is that? What is monogenic thalassemia? That is उसके लिए we have got only one gene, that is HB capital B. This is a normal condition. ঠিক আছে? And we know that there is a homologous pair for each chromosome. One from mother and one from father. So we get 2 allele. That is HB capital B, HB capital B. This is a normal phenomenon. But if for some reason these allele get mutated or deleted, This will be the cause of beta thalassemia. তাহলে normal condition এ কি থাকছে? HB capital B, HB capital B. But if anyone is deleted or mutated, this is the cause of beta thalassemia. So beta globin chain ka synthesis decrease ho jayega. So here alpha will not get beta for pairing. Same case as in alpha thalassemia. Beta chain ka synthesis decrease ho jayega. So alpha will not get beta chain for his pairing. Okay. So here is free access for alpha globin chain. Alpha is not getting beta, so its pair with own cell खुद के साथ ही alpha pair करेगा. हाँ. So forming the or may যখন এই বিটা চেইন পাচ্ছে না তখন আলফা হয় নিজের সাথে পেয়ার করবে নয় কি করবে নয় সে ডেল্টার সাথে পেয়ার করবে. আলফা when alpha pair with delta it's form HbA2. ওকে. আর যখন আলফা কি করবে কম্বাইন করবে with gamma then it's form HbF. তো আমরা যখন HPLC গ্রাফ করব না HPLC গ্রাফ দেখব তখন আমরা HbA2 এর ভ্যালু বা HbF এর ভ্যালু এই দুটোর ভ্যালু দেখে আমরা বুঝতে পারবো যে পেশেন্টটার বিটা থ্যালাসেমিয়া আছে না নেই বা আলফা থ্যালাসেমিয়া না বিটা থ্যালাসেমিয়া. We can predict that from the graph of HPLC. Okay. Now you look at the picture of beta thalassemia, please. So in normal condition এ কি থাকছে HB capital B, HB capital B. This is the genotype. Okay, in normal condition. If mutation occurred in one allele, that is when the genotype is HB capital B, HB small b. This is called beta thalassemia minor or beta thalassemia trait. যখন একটা জিনে মিউটেশন আর ডিলিশন হচ্ছে এবং ফর্ম করছে HB capital B, HB small b. এটা হচ্ছে জিনোটাইপ. ওকে. This is called beta thalassemia minor or beta thalassemia trait. These are absolutely asymptomatic or mild treatment needed here, but as because the altered gene present here, so he or she, the individual, can transfer the disease to the next generation. Clear? But there is a mutation in both the allele. If there is mutation of both the allele or deletion both the allele, this is called beta thalassemia major. Genotype is HB small b, HB small b. This is also called beta thalassemia major is also called Cooley's anemia. Why Cooley's anemia? Because Sir Thomas Cooley first described it. Okay, that's why it is called Cooley's anemia. This is the most severe form of anemia and must require treatment. Patient have to take regular blood transfusion. Okay, and further treatment I will say you in later stage. Okay, this patient is regular blood transfusion treatment, and for regular blood transfusion there may be iron overload so they need iron chelation therapy. That I will say in later. Now over to Debomita. Debomita will describe the comparison between these two, alpha and beta. Now over to Debomita.
Thank you, Patralika. It has been well explained by you. I hope I'm audible and visible both.
Thank you.
Hello? Am I both audible and visible?
Yes, ma'am.
Yes, ma'am.
Okay.
Debomita.
Thank you so much. Okay, so here I am. I will state you about the comparison between alpha and beta thalassemia. The basic difference is between the life expectancy. So I'll go point-wise. The definition is the reduced formation of alpha polypeptide chains for alpha thalassemia, and for beta thalassemia, it is reduced formation of beta polypeptide chains. The symptoms are more or less same, that is none or small red blood cells, hemolytic anemia, paleness, fatigue, jaundice, enlarged pain. And for beta thalassemia, you can also witness jaundice and gallstones. The diagnosis is smaller than usual RBC, genetic testing. For beta thalassemia, it is hemolytic anemia, genetic testing, high fetal hemoglobin, and hemoglobin A2 or lower than normal overall hemoglobin. The causes are, as described by Patralika, that the genetic mutation of alpha genes occurs on chromosome number 16 for alpha thalassemia, and for beta thalassemia, the genetic mutation of beta globin genes occurs on chromosome number 11. The fetal mortality is the major difference. In homozygous condition, Barth's hydrophobes fetalis occurs and the fetus dies in the uterus. In alpha thalassemia, however, for beta thalassemia, in homozygous condition, the fetus survives in the uterus because there is fetal hemoglobin, but the child will have severe complications later. Can I have the next slide? Yes. The alpha globin locus and the beta globin locus has been previously discussed by dietitian Patralika Dasgupta. However, I'll go through the same point again for a clear understanding. In the first case, one allele gets deleted, so it is a salient carrier. And the second case is for alpha thalassemia trait, when the 2 of it gets deleted out of 4. The third one is HBH disease, where 3 of it gets deleted and totally making it unstable with damage of RBC leading to erythropoiesis damage as well. So, and the last point is when the 4 alleles are lost, it forms HB bar, hydrophobes fetalis. So here the symptoms is very fetal, as the fetus can die in the uterus. For beta globin locus, beta thalassemia is a monogenic condition since only one allele is responsible for it. So out of 2, when one allele is deleted or mutated, it is called beta thalassemia carrier or trait. When both the 2 alleles are deleted or mutated, this condition is called beta thalassemia major. It is a very fetal condition. For life expectancy is 17 to 20 years. However, but in conditions where blood transfusion, iron chelation therapy are maintained, the life expectancy can go up to 40 to 50 years, but in rare cases. So the major comparison comes is that alpha is more severe than beta, because in alpha, the fetus itself dies in the uterus, but however, in beta thalassemia, the childbirth occurs, but then the lifespan is very short. Can I have the next slide? Yes, the molecular basis of beta thalassemia and alpha thalassemia has been discussed here. So thalassemia is mainly caused by deletion and or mutation to either the beta or alpha subunit of normal adult. Molecular basis of beta thalassemia is the structural beta hemoglobin chains are present, but mRNA production is inefficient or rapidly degraded, as you have seen in the previous slide. For alpha thalassemia, the structural alpha hemoglobin chains are deleted. There are only 4 alpha genes. So beta thalassemia, defect in beta hemoglobin chain synthesis occurs, which results in increased levels of unpaired alpha hemoglobin chains. However, in alpha thalassemia, defect in alpha hemoglobin chain synthesis occurs, results in increased levels of tetrameric beta hemoglobin chains. Can I have the next slide? So this one will be discussed by dietitian Patralika Dasgupta. Thank you.
Thank you, Debomita, for nicely describe the comparison between alpha and beta thalassemia. Now I am telling about the combination of hemoglobinopathies. So thalassemia can coexist with other hemoglobinopathies. The most common of these are, so we have to know first the others hemoglobin in our body. That is hemoglobin E, hemoglobin S, hemoglobin C, hemoglobin H, hemoglobin A, okay, hemoglobin D. So when thalassemia coexists with other hemoglobin, it is called combination hemoglobinopathies. That is hemoglobin E and thalassemia. It is common in Cambodia, Thailand, and part of India. It is clinically similar to beta thalassemia major or thalassemia intermediate. Hemoglobin S with thalassemia, common in African and Mediterranean population, are clinically similar to sickle cell anemia. What is sickle cell anemia? This is a vast chapter. I can't tell it in this short time. In this short time period of time, I can't explain it. Sickle cell anemia, there is so many things. Okay, with the additional features of splenomegaly. Okay, why there is splenomegaly? I will explain it later. Why there is splenomegaly in thalassemia? Okay, hemoglobin C with thalassemia, common in Mediterranean and African population. Hemoglobin C or beta 0. Beta 0 thalassemia causes moderately severe hemolytic anemia with splenomegaly with hemoglobin C plus B positive thalassemia produce a milder disease. Hemoglobin D thalassemia, common in northwestern part of India and Pakistan. Okay, that is the Pakistan, that is the Punjab region. So, different thalassemia are happening in different population or different region of our country or what region, what country. This is here. Okay, now clinical features. Now clinical features we will describe by Debomita. Please, Debomita.
Thank you,
Sir, next
Patralika.
slide, please. Sir, next slide, please. Sir, next slide.
Sir, can I have the next slide?
Sir, next slide, please.
I am asking something. So Patralika is unable to. Sorry. Can you please tell me about the trend in Purulia belt? Why the thalassemia is more common in this Purulia belt, and the research are also going on these areas. So any certain reason, Patralika, can you say about the thing? About the Purulia area. Purulia, those who are from Purulia, the students or the nutritionists, those who are from the Purulia, you can say also the trend in thalassemia is very high in Purulia. So, do you have any idea about that? That many researchers are also going to that particular area for the research, and Purulia we can find. Bijaya ma'am is there. Bijaya ma'am, can you please highlight on that part you were saying that last day?
Yes, sure. I guess I'm audible.
You are audible.
Okay.
Yes, ma'am.
Right. Actually, in West Bengal, particularly Ayodhya Pahad that we have in the Purulia region, there the beta form of thalassemia is very prevalent. And it is prevalent because like those who are into academics, you must have heard about this called bottleneck syndrome. Bottleneck syndrome means that when there is a major population with one particular mutation or one particular disorder, that keep on spreading to the coming generation. So what happened in Purulia was that in that particular tribal region, the genes which originated, that genes were mutated, right? And they were mutated for beta thalassemia. Now, slowly what happened when the population of that tribe keep on expanding, all the next generation, they started becoming thalassemic in nature. So they have actually developed a pure line, a recessive pure line, which we call in genetics. So as because it is a pure line, the genes are totally pure, all the genes are recessive in that population. So that is the reason why multiple researchers from different countries also, they come and they study them. They find out that how the gene is progressing and what are the myopathies, what are the different pathological disorders that are developing, right? So that is one very particular thing about West Bengal we can say in terms of thalassemia.
Thank you so much for highlighting. And anyone from Purulia is there? Those who can say about the thing? Okay, I'm sharing the screen. We'll take the questions at the end. Actually, I have unmuted. Patralika was unable to hear me. That's why. Okay, no issues. I'm sharing the screen. Debomita, you can go ahead.
Sure, sir. Thank you. Okay, so here are the clinical features. The clinical features include extreme anemia, shortness of breath, recurring infection, fatigue, heart problem, especially a burning sensation occurs, and iron overrated. Can I have the next slide? The explanation of the clinical features are here as well. So the symptoms of thalassemia vary depending on the type of thalassemia. For alpha thalassemia, it will be different, and for beta thalassemia, it is somewhat different. In infants with beta, sir, can I have the slide? Thank you, sir. In infants with beta thalassemia and some types of alpha thalassemia, symptoms usually appear after the age of 6 months. This is because the neonates have a different type of hemoglobin called the fetal hemoglobin, which has been explained by dietitian Patralika Dasgupta. After 6 months, the normal hemoglobin gets replaced with the adult hemoglobin. So there the symptoms begins to appear like pallor and ecteric skin, hypoxia, arrhythmia, shortness of breath, tachycardia, stunted growth, osteoporosis, thrombophilia, greater susceptibility to infection. It gradually rises. Skeletal deformities due to bone marrow expansion. Iron may accumulate from blood transfusions. Excessive iron can harm the spleen, heart, liver, and endocrine glands, leading to certain diseases like hypogonadism, hypothyroidism, diabetes, hypoparathyroidism. People with hemoglobin H, a form of alpha thalassemia, are more likely to develop gallstones and an enlarged spleen, as it has been discussed in the comparison between alpha and beta thalassemia. Splenomegaly, hepatomegaly, decreased RBC count due to defective globin chain formation and ineffective erythropoiesis, untreated, then the complications of thalassemia can potentially lead to organ failure. The next slide will be further discussed by dietitian Patralika Dasgupta. Thank you.
So now coming to the
Patralika,
topic.
could you please take over?
Yes, Debomita, thank you.
Thank you.
Okay, so now I'm coming to the topic laboratory diagnosis. Thalassemia diagnosis requires a combination of laboratory tests. So there are a number of laboratory tests to diagnose the thalassemia. First of all, red blood cell indices by automatic hematology analyzer. There are different type of red blood cell indices like MCV, that is mean corpuscular volume, that is MCH, that is mean corpuscular hemoglobin concentration, MCHC, that is MCHC, mean concentration of mean corpuscular hemoglobin concentration. দুটোর মধ্যে স্লাইড ডিফারেন্স আছে, MCH আর MCHC। যাই হোক, এই RDW that is হচ্ছে red cell distribution width, এই ডিফারেন্ট টাইপস অফ রেড সেল ইন্ডিসেস গুলো দেখে আমরা ডায়াগনোজ করতে পারি যে ইজ দিস এ কেস অফ থ্যালাসেমিয়া অর নট। আমরা একটা আইডিয়া পেতে পারি, বাট নট, দিস ইজ নট কনফার্মেটরি টেস্ট। Next is hemoglobin electrophoresis. This is a qualitative method. Okay. Next is hemoglobin estimation by HPLC. What is HPLC? High performance liquid chromatography. This is a qualitative method, qualitative procedure. By HPLC, we can know the value of HbA2, HbA, HbF, different type of hemoglobin. We can know from the value of HPLC. Next is complete blood count, that is CBC. Here we can check the level of hemoglobin, total RBC count. Okay. Next is reticulocyte count. What is reticulocyte? First of all, we have to know what is reticulocyte. Reticulocyte is a immature RBC, that is nucleated RBC. ইন থ্যালাসেমিয়া কি হচ্ছে, থ্যালাসেমিয়াতে আরবিসি গুলো ইনফেক্টেড হিমোগ্লোবিন থাকার জন্য ড্যামেজ হয়ে যাচ্ছে, নষ্ট হয়ে যাচ্ছে, সো ম্যাচিওর করতে পারছে না, আরবিসি ম্যাচিওর ফর্মে যেতে পারছে না, তার আগেই নষ্ট হয়ে যাচ্ছে। তাহলে আমরা কি পাবো, there is a increased level of reticulocyte count in blood. Normal level of reticulocyte in blood is 1 to 2%. But in case of thalassemia আমরা কি পাবো, increased level of reticulocyte count. Iron level, we must have to check the iron level or ferritin level. Okay, next is genetic testing. There is genetic testing. DNA analysis will show whether it is proven a case of thalassemia or not. Prenatal testing, this can show whether this is a fetus has thalassemia or low or any other types of anemia. By checking chronic venous sampling. This is actually this test, chronic venous sampling. This test actually done in early pregnancy to obtain fetal cell for the prenatal diagnosis. Okay. Next হচ্ছে amniocentesis. What is amniocentesis? আমি just একটু সংক্ষেপে বলছি what is amniocentesis. This test takes some amniotic fluid. Okay, this test takes some amniotic fluid for around your baby in uterus for checking of birth defects and any genetic conditions. Okay, in your baby. You can get this test at least 15 to 20 weeks of pregnancy. Okay. By chronic venous sampling test, by this test of chromosomal and genetic disorder like thalassemia, we can detect this type of disorder like chromosomal or genetic disorder like thalassemia. You can detect by chronic venous sampling test. Okay. Last is there are different type of therapies for cure thalassemia. Okay. Like number 1, blood transfusion therapy. Blood transfusion therapy. Next one is drugs. Different types of drugs are there. Next one is HSCT. What is HSCT test? What is HSCT therapy? This is an allogenic hematopoietic stem cell transplantation therapy in thalassaemic patient. This consists of substituting the thalassemic HSC bearing infective erythropoiesis with an allogenic one capable of effective erythropoiesis. এখানে একটা জিনিস বলার আছে, যেহেতু বেশিরভাগ আমাদের থ্যালাসেমিক পেশেন্টের ক্ষেত্রে ডিফেক্টিভ হিমোগ্লোবিনের জন্য কি হয়, আরবিসি গুলো এফেক্টেড আরবিসি গুলো ড্যামেজ হয়ে যাচ্ছে। কোথায়? এগুলো বোন ম্যারো রেটিকুলো এন্ডোথেলিয়াল সিস্টেমে সেগুলো ডেস্ট্রয় হয়ে যাচ্ছে, এফেক্টেড আরবিসি গুলো ডেস্ট্রয় হয়ে যাচ্ছে, এন্ড দিস প্রসেস ইজ কল্ড ইনফেক্টিভ এরিথ্রোপয়েসিস। ইনফেক্টিভ এরিথ্রোপয়েসিস আমাদের থ্যালাসেমিক পেশেন্টদের ক্ষেত্রে আমরা যত না এই হিমোগ্লোবিন এফেক্টেড হিমোগ্লোবিন অল্টার্ড হিমোগ্লোবিনের জন্য আমাদের যতটা না অ্যানিমিয়া হয়, তার চেয়ে অনেক বেশি অ্যানিমিয়া কিন্তু হয় আমাদের ইনফেক্টিভ এরিথ্রোপয়েসিসের জন্য। কারণ কি, আমাদের রেড ব্লাড সেল গুলো আমাদের মেইন ব্লাড স্ট্রিমে আসতেই পারে না, তার আগেই বোন ম্যারো আরি সিস্টেমে সেগুলো ডেস্ট্রয় হয়ে যাচ্ছে। তো আমি যদি এই যে থেরাপিটা HSCT থেরাপি, এই HSCT থেরাপির জন্য উইথ অ্যান অ্যালোজেনিক ওয়ান দ্যাট ক্যাপেবল অফ ইফেক্টিভ এরিথ্রোপয়েসিস, এই থেরাপিটা যদি আমি করতে পারি তাহলে কি হবে, সে ইফেক্টিভ এরিথ্রোপয়েসিস হবে। এরিথ্রোপয়েসিস মানে কি? ফর্মেশন অফ রেড ব্লাড সেল, এরিথ্রোপয়েটিক সিরিজ, দ্যাট ইজ এরিথ্রোপয়েসিস। বোন ম্যারো, যেটা বোন ম্যারো স্টেম সেল থেকে আমাদের সমস্ত সেলগুলো অরিজিনেট করছে বোন ম্যারো স্টেম সেল থেকে। যে কোনো নট অনলি বোন ম্যারো, যে কোনো স্টেম সেল থেকে, যেখান থেকে ফ্ল্যাটেন বোন রয়েছে, লং বোন রয়েছে, সেখান থেকে আমাদের কি করছে, সেলগুলো অরিজিনেট করছে স্টেম সেল থেকে। তো আমরা যদি সেটাকে ট্রান্সপ্লান্ট করতে পারি তাহলে কি হতে পারে, আমাদের ইফেক্টিভ এরিথ্রোপয়েসিসটা হতে পারে। ঠিক আছে। নেক্সট ওয়ান ইজ জিন এডিটিং। দিস ইজ আ vast procedure I can tell here in this short time. Okay, so next slide please. here is various type of various type of hematologic indices. Hematologic indices মানে that is MCB, MCH, MCH, RDW, RDW that is red cell distribution with মানে হচ্ছে red cell এর যে ডায়ামিটারটা, ওকে, মরফোলজি অফ রেড সেলের যে ডায়ামিটারটা, এটা কি হয়, রেড সেলের ডায়ামিটার RDW, এটা দেখে কিন্তু অ্যানাইসোসাইটোসিস মানে ডিফারেন্ট টাইপ অফ মরফোলজি অফ রেড সেল, এটা দেখে কিন্তু থ্যালাসেমিয়া হিমাটোলজিস্টরা এটা দেখে কিন্তু থ্যালাসেমিয়া ইন্ডিকেট করে অনেক সময় এটার ভ্যালু দেখে, when it is greater than 30, when it is less than 30. as thalassemia যেহেতু একটা জেনেটিক ডিসঅর্ডার, এর কিন্তু RDW ভ্যালুটা নরমাল লেভেলেই থাকে, কিন্তু যদি সেখানে আয়রন ডেফিসিয়েন্সি অ্যানিমিয়া হয় বা অন্য কোনো অ্যানিমিয়া হয়, সেক্ষেত্রে কি হয়, পার্নিসিয়াস অ্যানিমিয়া হয়, সেক্ষেত্রে কি হয়, RDW-টা আমরা একটা ভাস্ট রেঞ্জের মধ্যে পেতে পারি, কারণ সেটা হচ্ছে জেনেটিক্যালি রেগুলেটেড হচ্ছে না, ডিফারেন্ট ফ্যাক্টরস দ্বারা রেগুলেটেড হচ্ছে। সো RDW ভ্যালুটা হচ্ছে খুব ইম্পর্টেন্ট to indicate it is thalassemia or it iron deficiency anemia. Okay. Next one is prevention, prophylaxis and treatment. So next slide please. Slide number 23. This is a graph of thalassemia which you can get by HPLC method. Here is difference value like HbA2, fetal hemoglobin, different types of value of, this is a graph, HPLC graph. So next slide please. Prevention, prophylaxis and treatment. Here need premarital, preconceptional and prenatal screening test for thalassemia. So here, public awareness, clear conception about this matter is very important because we know this is a genetic disorder. So we can prevent it now. This is a genetic disorder. So we can prevent it. We have to check before marriage, before conception, we have to check if the father or mother is thalassemic or not, if they are carrier or not. So public awareness is very much needful here. So there are different types of treatment. One thing I must say, in case of beta thalassemia major, in case of beta thalassemia major, there is solution, there is the treatment, there is solution, that is bone marrow transplantation or gene therapy. Okay, that is bone marrow transplantation and gene therapy. It can cure, but this is a very much expensive process. Bone marrow transplantation or gene therapy, this is a very expensive process. Okay. I must say here one thing. In thalassemia major trial, where the blood transfusion is very important, blood transfusion must be a quality filtered blood. That is, it must be free from HIV, HBsAg, HCV, VTRL antigen, and group must be checked before transfuse the blood. Group have to check. Okay. And there may be the permanent treatment like bone marrow transplantation or gene therapy. This procedure is prone to complication and health hazards, very expensive also. Require the HLA-based donor also. HLA-based donor also required. So this is a complicated process, but successful rate are there. And one thing I want to tell here, that is, as a healthy sibling with no or minor thalassemia can be the donor. Okay, in such case, a transplant done at the early age of 5 or before is proven more successful comparison to the later age. Okay. One thing more, after a bone marrow transplantation, blood transfusion is not required. Successful bone marrow transplantation at pore, blood transfusion is not required. Okay, this is all about. And now over to Prashasti Chatterjee. She will explaining about the diet. Now over to
Hi.
Prashasti Chatterjee.
Hi. Thank you, Patralika. Good evening, everyone. I am Prashasti Chatterjee. As Sir has already introduced about myself, I am from Srirampur, Hooghly, and I have completed my graduation from Calcutta University with Food and Nutrition honors, and currently pursuing MSc from IGNOU. Last year, I did the 6 months MNT course from Cognized Nutrition, and through that platform, I came to know Mr. Shomendu Ghosh sir. And here, I would like to thank you, sir, for giving me this opportunity to share my knowledge about thalassemia, a very major inherited blood disorder, and yet to be known much more about it because there are many myths and misconceptions about it. So, my two presentation partner, uh, and dietitian Debomita Dasgupta and dietitian Patralika Sengupta, has already explained very well about the types and the other pathogenic conditions about this disease. Only the dietary part is left. And I am pretty sure that you all have cleared many of your doubts and questions regarding it. So, let's get started with the diet part and learn how to combat this situation with diet and some lifestyle modification. So, in the first slide, that the basic and common medical practice or diet practice for any disease or physiological condition is to maintain a balanced diet. And thalassemia is not an exception for that. Uh, so, for now, being in a nutritional background student or nutritional background, we all know that what is a balanced diet, and definitely not defining it here. But in case of thalassemia, we have to check some special essential nutrients, that protein, calcium, vitamin D, vitamin E, vitamin C, folate, and other some trace elements like zinc, copper, selenium, to combat the physical uh, stress of thalassemia. Okay, we have already discussed that in thalassemia there is an iron overload in the body. So, for non-transfused thalassemia patients, that is the patients who do not need uh, lifelong blood transfusion for survival, rather they require occasional transfusion or some transfusion in some clinical settings for defined period of time. They require a moderately low iron diet to avoid the iron overload in the body. But for the patients with chelation therapy, the patients who are getting chelation therapy, they don't need major iron restrictions in their diet, because chelates already are removing the excess iron from our body. So, next slide. Okay. Uh, sir, your screen is not sharing, sir.
Prashasti, I will request you to move a little bit faster.
Okay, okay, sir.
Please move faster.
Okay, okay, sir. Sir, can I have the slide, please? Okay. The importance of protein. The word protein is derived from the Greek word proteus, and this means of prime importance, as protein is required for our body, for our bones, muscles, tissues, cells, hair, etc., to function properly. And in thalassemia children, the growth and development slows down, and there is a high risk of infection during blood transfusion. So, a high protein diet is recommended to combat this situation. But we have to select the protein sources very wisely. At most of the rich sources of protein, that is the animal protein, is also the rich source of iron. So in that case, we can consume eggs and other animal source, plant sources of protein, that is seeds, nuts, and dairy products, etc. in case of thalassemic patients, and avoid as much as possible the animal proteins. So next slide. Okay, now what is the importance of calcium and vitamin D in thalassemia diet? Now, thalassemia causes many bone problems like unnatural bone structure, especially of the skull, widening of bones, less of bone density, joint pain, etc. So keep that problems in check. A high calcium and high vitamin D diet is recommended, as together with calcium and vitamin D plays a very major role in our bone mineralization. Other than that, calcium and iron are antagonistic. So calcium is also recommended in diet to decrease the absorption of iron in our body. Okay, so what are the sources of calcium and vitamin D? The milk and milk products or fish liver oil, they are the sources of calcium and vitamin D. And beside this, vitamin D is most likely to be synthesized in our skin. So, midday sun exposure for 10 to 15 minutes daily can synthesize a good amount of vitamin D in our skin. And researchers also have shown that the fairer skin tone um, more quickly synthesizes the vitamin D than the darker skin tone, because there are the different types of melanins in the skin. So next slide. Okay, now the importance of zinc. Zinc is a micronutrient, and that plays many vital roles in our body, such as immune function, growth and development, enzymatic function, gene expression, protein synthesis, wound healing, DNA synthesis, and many more. But our body cannot synthesize or produce or store zinc, so we must have to have zinc uh, through our diet. Uh, Keeping the in mind the iron content in food, because most of the iron containing food also contains zinc. So here we also have to select the animal source, the plant sources of zinc, that is whole grain, eggs, nuts, seeds, and the animal sources like meat, fish, egg, etc. should be egg should not be discarded. I'm very sorry. Meat, fish, they should be discarded or avoided from the diet. Other than that, folic acid or vitamin B9 is also uh, suggested to keep in diet, because it also helps to develop the red blood cells. Okay. So it is also very important to keep in diet. Now the next slide. Okay, now we are getting into an interesting part. As we all know that vitamin C is known to be an enhancer of iron absorption. It increases the rate of iron absorption. So in case of thalassemia patients, uh, vitamin C should be discarded from the diet, as it can also increase the iron absorption. But ideally, but practically, it should not be done, because other than that, vitamin C also has a antioxidant property. And in thalassemic patients, during blood transfusions, there is many oxidative stress, and to neutralize the oxidative stress and to neutralize these kind of problems, antioxidant is required. And for that, vitamin C and vitamin E, these kinds of antioxidants are very much required in our body. So next slide. Other than antioxidant, vitamin C also helps to remove the iron from liver store. Okay, and it also associated with ineffective chelation, and it also helps to non-heme iron absorption. Non-heme iron are present in the fruits, plants, plant-based sources of iron, and these are the non-heme iron. They should be included in diet. And vitamin C is an enhancer of this kind of iron is absorption. I think you all have uh, understood my all slides. Now going to the next slide. Sir, next slide. Okay. It is often seen that thalassemia patients are at risk for nutritional deficiencies. Why so? Let's get into the points directly. It can be caused either due to poor intake or poor appetite. Okay. Uh, because making the nutrients less available for the body to function properly. Sometimes there could be food intolerances and for that decreased consumption of certain nutrients. For example, if a thalassemic patient has lactose intolerance, he cannot take milk or milk products, and this obviously leading him to have a calcium deficiency in his body. Other than that, to purposely avoid some nutrient like iron in case of thalassemia, sometimes patients get less amount of other nutrients like protein, zinc, etc. because their sources, food sources are almost similar. Because other than that, uh, tannin, caffeine present in tea or coffee, they have been shown a mm, mm, beneficial effect on thalassemic patient because they decrease the iron absorption. তারা iron absorption কে কমিয়ে দেয়। তো thalassemia patients sometimes replace many nutritional beverages with tea or coffee. তারা বিভিন্ন রকম মানে চা আর কফিটা বিভিন্ন মিলের সঙ্গে নেয় এবং তার বদলে বিভিন্ন রকম নিউট্রিশনাল যে বেভারেজ গুলো, বিভিন্ন নিউট্রিশনাল যে হেলথ ড্রিঙ্ক হয়, সেই হেলথ ড্রিঙ্ক গুলোকে তারা ক্যান্সেল করে দিয়ে টি এবং কফি নয় টু ডিক্রিজ দ্য রেট অফ আয়রন অ্যাবজর্পশন। ঠিক আছে। আর in case of thalassemia, there is already an iron overload in the body, and as I previously discussed that iron overload in the body leads to increased oxidative stress and thereby need more antioxidants like vitamin C, vitamin E, etc. If the intake of these antioxidants are poor, the greater the expenditure and poorer the intake, there could be a deficiency. And last but not the least, patients with chelate therapy often experience nausea, cramping, and other symptoms for which they sometimes miss their meals, and for this they also cannot get proper nutritional um, benefits. Now here comes a questions in our mind that if in this scenario, if a thalassemic patient can take supplements or not. Yes, the patients can definitely take multivitamin or multimineral supplements, but certainly suggested by their consulted physicians only. Without any recommendation, one should not take any supplements. Okay. Now, let's check what are the foods that decrease iron absorption. So they can be added in our diet. They are whole grain cereals like wheat bran, maize, oats, rice, tea and coffee. More precisely, tannin and caffeine. Dairy products as they are high in calcium. Phytate containing foods like whole grains, legumes, nuts, seeds, tubers, etc. And oxalic acid containing foods like leafy vegetables, preferably spinach, soy products, berries, etc. And what are the foods that increase iron absorption? Now, vinegar fermented foods, vitamin C rich foods, pickles, soy sauce, etc. can increase iron absorption. Now, here is a list of iron rich food, that is meat or red meat, fish, dry fruits, green leafy vegetables, legumes, vitamin C rich fruits, beetroot, nuts, and seeds. Here I come with some dietary tips to maintain a healthy life. First, check if the cooking or eating utensils are of irons. If yes, then discard them, because this can also overload the iron content in our food, and through that our body. And eating junk food, carbonated beverages, foods with preservatives, processed foods should be discarded. Ginger and honey have um, anti-inflammatory properties and have shown to give relief from thalassemic patients. So they can also be added in food. Now we have come to the end part of the session. This is the FAQ session. I have already put some commonly asked questions. First question is iron deficiency related to thalassemia? Now, can you want to give the answer, or I will give it? Any one of you want to give the answer? I think I should give it. Okay. No. Alpha thalassemia and iron deficiency anemia is both the different thing. Often, though alpha thalassemia is frequently mistaken for iron deficiency anemia because both disorders have microcytic red blood cells, but in uh, alpha thalassemia, iron therapy is not required, and the procedures used to find a source of bleeding in patients with iron deficiency anemia have no value in patients with thalassemia. Okay, so they are different from each other. Now, the next common asked question is, set the next slide, that how does iron affect thalassemia? That how does iron affect thalassemia? Because in major thalassemia, maybe due to multiple blood transfusions because of ineffective erythropoiesis and increased gastrointestinal iron absorption, lead to iron overload in the body, and this is a very common complication of thalassemia, and this can lead to organ damage and increased mortality. In this way, iron affect the thalassemia. Okay, so already I am at the end of my presentation. Hope you find my presentation informative and helpful. Thank you for supporting me to continue my session. Now I would like to ask dietitian Debomita Sengupta to further continue with the rest of our session. Thank you.
Thank you, Prashasti. That was really very
So we'll move
interesting
to
and
the question
informative.
answer session, and there are seniors, so I request my seniors if there is any feedback or questions. So we'll take your suggestions. Then I will move to Vijaya ma'am for any feedback or anything. And this
Sir,
is
can I just go through with the take-home message?
Yes, it was not in the slide, so it is not required, Debomita. Take-home message and everything was very nicely described. So due to crunch of time, we will go directly to the question and answer.
Sure,
so there are many questions already put in my WhatsApps, and first I will like to invite Vijaya ma'am. So Vijaya ma'am, if you give a keynote about that thalassemia and its importance. They have tried their level best.
Right. It was a wonderful presentation. All three have worked very hard and it was very nicely presented. And as a whole, what I believe is, yes, definitely the West Bengal, our own city, Kolkata, is definitely at risk of thalassemia. If you see on an average, you will find that out of 10, at least one individual is carrier. And then also the awareness is not yet very much there in the community. So being dietitian, the first and the foremost thing that you must do is to make people aware. That's very important to get detected, to diagnose yourself. And of course, there is another major misconception that you will see in community is that people think that if a particular individual is carrier maybe, and then that particular individual will definitely give birth to a thalassemic child. This is a very, very problematic concept. So being the nutritionist, you deal with people, you counsel the people, so make them aware that what is the proportion, what is the percentage, what is the probability of this genetic disorder transmission. That I believe is one major thing that you must be doing at your end, right? Or else the information all which is given is very helpful, and all the best from my side. If there is any question, then definitely we are open.
Okay, Nina ma'am, are you there? We are really privileged that Nina Singh ma'am is there. So she's
Yes,
a very
I'm
senior,
here.
and she's in the national ITA body. She was the retired dietitian from BP Podar Hospital. So ma'am, can you give some valuable feedbacks? You have joined. It is really privilege for all
Well,
of us.
I joined in between some Hindu because I'm not in Calcutta.
Okay.
And the connectivity is not too good, but I would like to
ma'am, I will share you the video. The pathogenesis is very nicely explained by one of our dietitian, and she is working in a lab, so she has good connection with the pathologist. So
okay,
I will
that would be wonderful.
Obviously share you the YouTube video, but whatever you have joined, it is really privilege for all of us.
Thank you. I'd just like to make a comment that it's a very important topic which you all have covered, because a lot of people are not aware of on this, you know, and they have their doubts, etc., which we have to clear by bringing about awareness of the subject and the diet, what's to be given and all, very important. So I think it's you touched upon this. I'm really happy and very good. I would like the slides to be, you know.
Yeah, I will send you, ma'am.
Yeah,
and I will send you, because it is the awareness is very much required for the people.
Absolutely, absolutely.
People do not know, and people get very much tense when diagnosed with thalassemia.
Yeah, so, it's a rare topic. People are, I mean, like, it's not touched upon very commonly. So that's why it's been really informative. And I think we need to educate the people on this more, you know.
Right. So I am sharing a recent case study. So those who are the participant or the speakers, can you comment on this case study? It will be a great if you comment, or if our Bijoya ma'am can comment that if really iron restriction is required or not. I am going through the case study. This is the case study. The child is 7 years, 3 months and 21 kg. The height is 123 centimeter. And in the BMI percentile is more or less 50th percentile in the IAP growth chart. So this is the report. Patralika, if you are there, if you can go through the report, already I have sent it to you. So this is the child report. Hemoglobin is 11.9. So as per it's quite good. But I think it is the carrier. If you can just check on this.
HbA2 value কত আছে? HbA2 আর HbA value?
Let me check first. If you, I am going through the slides. You just have a look. These are the few medications for some other reasons doctor has prescribed. This is vitamin D, which is 56. This is another. This is the height, weight, and BMI percentile chart. And it is written here, it is beta thalassemia minor, and HPLC HbA2 is 4.2%.
Okay, sir, আমি এটাই জিজ্ঞেস করছিলাম, HbA2 ভ্যালু যদি গ্রেটার দ্যান 3.5 হয়, আর হিমোগ্লোবিন এর যেটা HbF তার ভ্যালু যদি 1 এর বেশি হয়, কেন কি নরমাল লেভেল হচ্ছে 0.8 থেকে 1 অবধি HbF এ, সেটা যদি গ্রেটার দ্যান 1 হয় তাহলে আমরা সেটাকে সাসপেক্ট করি বিটা থ্যালাসেমিয়া মাইনর হিসেবে, কারণ বিটা থ্যালাসেমিয়া মেজরটা খুবই আনকমন,
হ্যাঁ, তো সেটা আমরা ডিটেক্ট করি বিটা থ্যালাসেমিয়া মাইনর হিসেবে বা ট্রেট হিসেবে। আবার যদি
Okay.
HbA2 এর ভ্যালুটা যদি 10 ক্রস করে যায়, 10 বা 10 ক্রস করে যায়, সেক্ষেত্রে কিন্তু আমি যেটা একটু আগে বললাম হিমোগ্লোবিনোপ্যাথিস, সেখানে আমরা HbE প্লাস A2, সেটাকে আমরা বলবো HbE প্লাস A2, মানে অনলি A2 এর ভ্যালু গ্রেটার দ্যান 10 হতে পারে না। সেখানে যদি অ্যাবনর্মাল হিমোগ্লোবিন ই প্রেজেন্ট থাকে তাহলে সেটা 10 ভ্যালু দেবে, বা মোর দ্যান 10 আপ টু 50 অব্দিও দিতে পারে। তখন আমরা সেখানে আইডেন্টিফাই করব শুধু নট অনলি A2, তার সাথে কম্বিনেশনে হিমোগ্লোবিনোপ্যাথি রয়েছে, সেটা ই। আর
And
অলওয়েজ
if you can
মেজর
check the iron
থ্যালাসেমিয়া,
report, Patralika, this is the iron report is there, total iron binding capacity, and all these are here present. If you can go through this and just have an interpretation on this. আমি একটা ওয়েবিনারে আছি, আমি জাস্ট বেরিয়ে ফোন করছি। So I think everything looks normal here. The total iron binding capacity and everything is normal here. And if you can see, the serum ferritin report is also attached here with. So Bijaya ma'am, do you want to say anything about this particular case?
Yes, like you have already mentioned that the hemoglobin
I
value.
think both the mother and the father are carrier. The mother's and father's report is not attached here. Fatma has not attached here, I think, or it is attached. I missed. Yes, you can go for your interpretation.
Right, as the child is already being diagnosed, and yes, being minor, the child is not showing up vast symptoms. Like you have also dealt with this particular patient, and you have seen that till now the child is doing well. And mostly, I believe the child was diagnosed by the age of 11 years, right? Yes.
It's 7. Ma'am is saying something. Seven years, Vijay, 7 years.
Okay, right.
Recently diagnosed.
Recently diagnosed, right? So basically we have seen that if the condition is critical, or if the particular child is homozygous, or the particular child is already in a major condition, so by the age of 3 or 3.5, complications are seen. The person will develop mild jaundice symptoms, and then hepatomegaly and then splenomegaly, all one after the other. So as per the report, as the hemoglobin level are still good, but then yes, we can check the values of iron. That is what we always do from our side. Yes, so as a whole, the child is still fine, but then if we want, we can restrict, we can just try to reduce the iron load, and of course vitamin C, of course it should be checked.
Can reduce the animal protein bit, so can we suggest that and go for this?
Yes,
meat,
plant protein,
meat
plant sources will be good, because there we already have this phytates available, so that will also reduce the iron absorption. That is one particular advantage of utilizing the plant sources, if we are not using the direct animal protein.
Right. Debomita, Vijay, I'm going to the question answer session. So Debomita, one by one, if you can take the questions from this chat box as well as from our WhatsApp group. So
hello, Vijaya.
Yes, Shushmita, yes.
Just I have joined. Sometimes we can also advise our patients.
We are discussing about a case study, Didi. Right now you have joined. So we have discussed a case study, which is Beta Thalassemia minor of a child who is 7 years old. So Vijay was giving the answer for that particular case study. Just for your information, I have just told you, and already we have many senior dietitians also today. Thank you, Didi, for joining. Yes, Didi, you can continue with your question.
No, I don't know that this is case study. Actually, I have just joined.
This is the case study, Didi, in the screen.
Okay.
And this is the interpretation of the doctor. Here, the beta thalassemia, it is written minor. It is not the major. And both the parents are carrier here. And the growth is also not up to the mark. But it's
Sometimes
okay.
patients are asked to have green tea or tea after having,
Yes, it is discussed in our slide. It is discussed today's in a presentation. I will share you the presentation. It was really nice that they have covered each and everything, especially the pathogenesis part they have covered very nicely. And Patralika is working in a lab in ESI hospital. So she is working with the pathologist and she has prepared the slide consulting with the pathologist. So it was nice. So yes, Debomita, can you please go ahead with the questions?
Sure, sir.
And what Patralika was describing about that bone marrow transplant and all this, obviously in India it is very costly and for the patients to bear that cost. But yes, obviously there is a treatment for the major also. Right, Patralika? You are telling about that bone marrow transplant.
Yes, sir. Bone marrow transplantation and also gene therapy.
Also gene therapy. Okay. So
Yes,
how
sir.
long does it take, the gene therapy and all these treatments? It is a lengthy procedure, I hope, because
Yes,
I don't have the idea. Yes,
yes,
Vijaya.
Patralika, you can answer. Right.
Actually, ma'am, hello.
Yes.
Yes.
I'm telling that the condition is caused by cured by bone marrow transplantation, and here a healthy sibling with no or minor thalassemia can be the donor, because I'm telling a healthy sibling with no or minor thalassemia, because here HLA typing is very much necessary. তো যদি কোনো ডোনার না পাওয়া যায় তাহলে সিবলিং যদি ট্রেটও হয় তাহলেও কিন্তু সে ডোনেট করতে পারে, স্টেম সেল ডোনেট করতে পারে। সেটা সেটাও কিছুটা
Okay, right. Actually, basically, it is a lengthy process. এটা একটু lengthy process. I tell you why. Because when we do gene therapy, first হচ্ছে stem cell collect করা, then ওই stem cell টাকে culture করতে হয় so that it can be introduced. Same for gene editing. First you culture it, then you use a vector. The vector will modify the cell and then you put it. আর এটাও না যে এটা one time solution, সেটা আমরা বারবার বলে থাকি, but then they do have a lifespan. After that you have to repeat this process. তো এই জন্য এটা একটু কমপ্লিকেটেড, অ্যান্ড দেন দ্য ইন্ডিয়ান জেনেটিক যেটা আমাদের কাউন্সিল যেটা আছে, যেটা ডিটারমাইন করে দ্যাট এট হোয়াট ফিচার্স ইট শুড বি ডান, সেখানে এখন অব্দিও থ্যালাসেমিক কেসেস খুব বেশি রেজিস্টার্ড হয়নি। সো দ্যাট ইজ আ ডিসঅ্যাডভান্টেজ, বাট ইয়েস যদি এটা করা যায় ইটস আ ভেরি প্রমিসিং ফিল্ড টু ডু।
আর এটা খুব কন্টামিনেশনের চান্স থাকে প্রত্যেকটা স্টেপে, খুবই স্টেরাইল কন্ডিশনে করতে হয় প্রতিটা স্টেপ।
হ্যাঁ, সেটা যে কোনো সেল কালচারের ক্ষেত্রেই, as because we are dealing with stem cells, তো যেটা খুব কষ্ট করে পাওয়া যাচ্ছে, it has to be sterile.
So Tasnima have a question. Hope Tasnima you got your answer why thalassemia is more prevalent in Mediterranean and Asian countries. So the answer is already given. Already given. Sharmishta Mitra is how the thalassemia is diagnosed. It is already answered by Patralika. The role of diet in thalassemia, do's and don'ts, already answered. Pooja Vishwas, what are the different diet preference for alpha thalassemia and beta thalassemia? So hope the answer is given in this presentation. If it is not clear,
like to take this question that why
please Debomita
rich in iron should not be given. I have already answered in the chat box, but also I would like to explain about it, that animal protein has the iron which gets directly absorbed due to the heme iron. The ferric valency is there, but in case of veg, the non-heme iron is there. It is in ferrous form, so the iron absorption will not occur in absence of vitamin C. So vegetables can be taken while the animal protein is restricted in some cases.
Good. Would you
also
like to
another
answer?
Question was there, sir, regarding what should be
would
done.
You like to answer this question? This is important. What is true thalassemia by Ranjita Bose, an effect of thalassemia on pregnant and lactating mother?
Sure, sir. True thalassemia is a thalassemia case where the gene is dominant, beta major, and for pregnancy already there is a stress, so it further increases the cardiac stress, anemia, and for lactation also it increases the stress, so it becomes an overstress condition. So this is the probable answer.
Achha, who have asked this question, important question about the splenomegaly in our batch 4? Who have asked this question? Vijay ma'am will give the answer. Somebody have asked about the splenomegaly in thalassemia.
Okay, Arunima has asked, I guess.
Arunima has asked. Okay.
Right.
So, ma'am,
Yes.
can you please give the answer? What
Right.
is the reason of splenomegaly in thalassemia?
Yes. So, like we know, we have already discussed till now. That
And also splenectomy in the patient.
Yes. So, like exactly we know that in this particular group of patients, we see that there is random degradation of RBC and hemoglobin. And we also know that spleen is the graveyard of RBC, right? So, when they are dead, when the RBCs are dying, when the hemoglobin has to rupture, then definitely they all are going to the spleen. And there is a huge rush of dead RBCs by that time. So, as a result of which, there is a deposition that happen in the spleen, and we see a swollen structure, and we call it as splenomegaly, right? Now, what happens in case of major patients where we know that this is what is going to happen, and the spleen is undergoing all this trouble, and the spleen is by that time of no greater use. So at that case, the spleen is removed. So that is what is the splenectomy that is being done. Am I clear, Arunima?
Thank you. Thank you. Arunima, it is clear?
Yes, ma'am. Absolutely. Absolutely, ma'am. Thank you for this.
Thank you. Thank you. Debolina Vishwash, can you please go ahead with your question? I am reading the question, Debolina Vishwas. If a baby born with thalassemia due to her parents, what should be the precautionary food? This has already been answered, and Arunima has one more question. Debomita or Prashasti, you can also take this question. That if chelate formation is there, or if there is a thalassemia patient, should we totally restrict iron? Totally restriction of iron. Prashasti, if you can switch on your video and give the answer.
Okay, not required. Total restriction of iron is not required.
Yeah, Prashasti has covered the diet. So Prashasti, what you will say on this?
Yes, sir. I have already covered it in my presentation.
Covered. Yes.
That iron restriction is not required for chelation therapy because chelates already removing the extra iron from the body. So also there is there any iron restriction, that then it can be problematic for survival.
Right. And thank you so much for the answer. And also you have recommended for the tannins and use of tea and coffee after
Yes,
having
sir.
the
Yes,
veg proteins or which
Yes,
contain
sir.
iron. And
Yes,
which nutrient other than iron, calcium, and vitamin D, and apart from the antioxidant, should be taken care for transfusion patient? And what should be the calorie need is as per the ICMR, what is the need of the calorie for the children, and which type of iron the dietary source is most suitable. Always it has to, already it is covered by Prashasti.
Perfect.
And Prashasti has already tell about the ferrous and ferric forms of iron. So Arunima, the questions are very good, very relevant questions. So hope we have answered all of your questions. Still, if you have any doubt also, any questions regarding thalassemia, so please unmute and ask so that our speakers can give the answer. Our experts are already, our faculties are also there. So please clear your doubts in the today's session. Near future, we will again come with this kind of topic. No questions, I think. Do you find it very tough?
One question is there from my side. Some of the
Shushmita ma'am is there.
It's been found that some of hematologists have been advised our patients not to have banana. Not to have banana. What's your message?
I am giving the answer, but before that, I want the speakers to give the answer. Those who are today's speaker. ma'am is asking to have banana. It is ripe form or unripe form. She has not mentioned, but any form. Do you recommend banana?
They ask not to have, avoid banana.
Banana, or even I will say about the pomegranate. First, tell about the banana. Debomita? Debomita? Prashasti?
Yes, sir.
Banana is having only 0.4 microgram per 100 gram of the fruit, that is iron. And also that pomegranate is also not high in iron. People think that pomegranate is very high in iron. So this kind of fruits is not restricted in the thalassemia patients.
Exactly. This is not at all relevant.
This is a meat.
Yes.
This is a meat, and this is a veg protein,
Right.
and even coming from a fruit, so not even pulses or dull products.
Exactly.
So it is a low-graded protein, and these proteins are not readily absorbed in our body. So it requires some combination of vitamin C. For this, even people have this myth about the banana and pomegranate. So these are not even dry
For
fruits.
pomegranate, the iron is 0.3 mg per 100
Yes, it is 0.3 and banana is 0.4.
So it is very 0.4. So it is
They are
very
actually
less.
If you check the liver,
iron perspective, they are not saying from the vitamin C actually.
yes.
Sir, I think mainly the animal source of irons should be restricted to get the benefits for
Yes, if you see
thalassemic patients.
the liver, the red meat liver, it contains 17.9, that is almost 18 mg of iron, whereas this banana or pomegranate is only 0.3, 0.4. So this kind of things should be restricted because বাচ্চাদের একটা মেটে খাওয়ানোর প্রবণতা থাকে মা বাবাদের যে মাটন মেটে, এই অ্যাওয়ারনেস গুলো ইম্পর্টেন্ট ফর দ্য চিলড্রেন, not and also the clear the myths, because they have many myths, and you as a nutritionist or dietitian, you need to know what are the nutrient of particular foods. Otherwise you cannot talk with the doctor. What Shushmita ma'am was saying, if the doctor has recommended, you cannot say against the doctor, but if you have the scientific base, then obviously you can talk with the doctor. For example, for some nutrition supplement also, many of you are working for some pharmaceutical companies or nutrition companies. So if doctor is restricting your particular nutrient, then you can also say that, sir, this is having this amount of iron and this can be given. Shushmita, you can remember about our Pamelia. Pamelia was working with this thalassemia patient, and she used to talk with the doctor in this form only. Okay, so if we have no more questions, we will conclude today's session. So it was really enriching, and people have asked many things. Still, if you have any doubts, those who are new batch students, you can always put me the question in the WhatsApp. So our speakers will answer, or our faculty will answer.
One question is from my side, that are
please, we are ready.
Do you people recommend some supplements for them, for the children, thalassemic children?
Supplements, you can take the questions, whatever. Patralika, your slide has already that part, supplement. Sorry, Prashasti,
yes,
not Patralika, Prashasti.
Yes, sir. I have already mentioned that thalassemia patient can definitely take multivitamin or multimineral supplements, but they should certainly consult with physicians or their consulted doctors, because without recommendation or without any consultation, one should not take any multivitamin or multimineral or any kind of supplements with their own based knowledge. They must consult experienced dietitian or experienced doctor or any person from medical field.
Okay.
So the healthcare professionals must be,
yes,
I mean, must guide them before taking any iron, folic acid, vitamin D, or calcium supplements.
Yes, unless and
the right amount can be determined by them.
Determined by them only. after.
Yes.
And Shushmita, the one thing they were describing, that if recommendation for iron supplementation is only there after checking the total iron profile, not only hemoglobin, that is ferritin, iron
Ferritin
binding
profile
capacity,
mentioned.
everything should be checked. Then only doctor will decide. Not only checking the hemoglobin, we will prescribe iron supplements. And already Prashasti has described about the folic acid supplementations. That part she has nicely explained in her presentation. Orunima, you have raised hand, no questions. Today their raised hand is very less. In our other classes, there were too many raised hand from batch 4. So Orunima, any more?
Sir, it was by mistake. I think I didn't see it. Sorry.
So hope everything is clear. Shraddha, I have to leave. Yes, we also have to leave. It is already late. So thank you everyone, and have a nice day. Good night. And tomorrow's class we will decide, and by tomorrow morning we will give you the class notice. Thank you so much, and we'll come up with more new topics, new presentation. Please suggest us new topics, new presentation, and I want all of you to participate and create the awareness through online or offline session. We can create awareness. Last was our hypertension, and today was our thalassemia. So you can choose short topic. You can make group. Like first of all, I will give priority to the batch 3 people. Before getting the certifications, you have to make small groups, and you have to do the presentation. It is mandatory, and for the batch 4 people also, it is mandatory to do presentation. So from today onwards, please prepare as your own, and it will enhance your knowledge. Thank you everyone. Thank you Nina Singh ma'am. Thank you Shushmita di, Vijaya ma'am, other seniors, and all my junior students. Thank you so much.
Sincere gratitude, and thank you to all for joining. Thank you, sir, for giving us this platform.
Okay. So after leaving the session, Debomita, only the participants I will request again to join. But first I will end the call. Then again we will join for 2 or 3 minutes for a discussion.
Sure, sir.
Okay, sir.
Good night.
Okay, sir.
Good night.
Okay, sir.
Good
Thank you,
night.
everyone.
Thank you.